This is one of the most interesting cases I've seen to date, and I got this patient back 13 years for a follow-up. Stick around. I'm Bill Nudera. Welcome to my channel dedicated to clinical endodontic education. We see some pretty interesting things from time to time, and this one was no exception. Tooth number 26, lower right number 2. The patient was referred to me for surgical root canal treatment, and the prior root canal was completed about 8 months ago. This case predates my CBCT scanner, so all I've got to work with here is that two-dimensional projection image. I wasn't quite sure what to make of what I'm seeing, but here's what I did see. There's been a prior access preparation through a full coverage restoration, and I see this radio-opaque line lying somewhere there horizontally in the coronal third of that root. There's also an associated periapical radiolucency. The tooth was asymptomatic and functional, but the patient complained about a bump on their gums that just wasn't going away. How many times have we heard that chief complaint? I've got a bump on my gums. But what do we think? We think sinus tracts, we think chronic apical abscesses, we think little localized swellings. But I wasn't exactly sure what was going on here until I took a look intraorally. This is no sinus tract. This is gutta percha, and that gutta percha is protruding through those gingival tissues. You know that surprise face emoji? Well, that's what my face looked like when I saw this clinically. And now that PA starts making a little bit more sense to me. I'll bet that original root canal access was misdirected to the buccal and there was some buccal perforation that occurred. Either that perforation was unrecognized or frankly ignored, and the treatment proceeded and the clinician chose to complete the process. It's really difficult for me to understand what goes through a clinician's mind when they choose to complete a root canal treatment like this. Clearly, when we look at this, we know that there's a problem. But instead of addressing that problem, the patient is then told that the only way they can have their tooth survive is through a surgical option. Iatrogenic errors occur in every clinical practice, and no one is immune to them. But there are so many steps within this root canal treatment that either were skipped or ignored that could have given the clinician a clue that something was going on. A couple of obvious ones to me are the discrepancies between the initial estimated working length and the actual working length while you're treating the case. Another obvious misstep is the lack of mid-treatment images. Working images, wire measurements, cone fit images would have picked up a problem pretty early on in a case like this, and maybe, just maybe, it could have been avoided. After consulting with the patient, we came to the conclusion that apical surgery probably wasn't the best option moving forward here, so we chose the retreatment process. At visit 1, I accessed the tooth, I was able to retrieve that gutta percha cone, I identified and repaired the perforation, and located and treated the original canal. I was fortunate enough to retrieve the material in one piece through the access. I placed that calcium hydroxide, it's marginal at best, and I scheduled the patient for a second visit. At 4 weeks, we can see complete soft tissue recovery. The treatment was completed at the second visit, and I closed the access with a bonded composite resin. I was able to get this patient back at 2 years, and the lesion had healed, at least according to the two-dimensional projection image, and that soft tissue remained normal. The tooth was asymptomatic and functional. At 8 years, the periapical image shows that the area has remained stable with no signs of apical pathology. At 13 years, we see absolutely no unfavorable changes here. Our PA shows, again, no signs or changes in the periapical status. I did capture a cone beam scan at 13 years. The coronal plane shows no signs of apical pathology. It looks stable. The sagittal plane shows where that area of misdirection and perforation originally occurred, as well as my repair. I am always absolutely thrilled to get these long-term follow-ups, especially on these cases with these iatrogenic issues, because what it does is it shows us that when we can apply our protocols and in the right conditions, then the outcome statistics are extremely favorable. Well, I hope you've enjoyed this video presentation today. And if you haven't already, don't forget to hit that subscribe button. I'm Bill Nudera. Thanks for watching.